now we're going to do the scapular Y view as part of a shoulder series. I'm going to have you put your arm across.
This one?
Yes.
Here.
Okay. So I'm going to have you turn around and face the board. For this one, I am going to change the orientation of my film to lengthwise to match the shape of the scapula. I'm going to move my marker to the other side, and I'm going to turn it around so it's PA and it will match when the image flips. On the other side of it. So I have my patient put their arm across their tummy. So that's where Julie's arm is right now. I'm going to have her turn at about a 45-degree angle to the bucky. And I'm going to feel for the scapular spine on the back of her shoulder. I'm going to try to get that scapular spine as close to perpendicular as possible. By putting him in a 45-degree angle, it's going to pretty much do that on its own. But I'm just going to double check it by putting my two fingers, my index and my middle finger, on the scapular spine. And that helps me visualize that it's definitely perpendicular. We're going to center to mid-scapula. So I can feel her scapula ends right about here. So the centering is right about right. I just need to make sure that my light field matches my lengthwise cassette. And on here, you can see that the lengthwise is already denoted for you. I'm going to make sure my marker's in there. I'm going to pull you back just a little bit. Right there. All right, and she has her shield. All right, I'm going to ask you to hold your breath, don't breathe, don't move, and expose. And you can go ahead and breathe. So now I'm going to show you the AP scapula. So I'm going to have you stand with your back against the board. And this is also a lengthwise projection to match the shape of the scapula. For this one, you're going to center at the same place as the shoulder. You're going to collimate tighter because we really only need the scapula. And then the last thing I do is I'm going to have the patient raise their arm into like a 90-degree angle right there. And I'm going to make sure that I still have bottom of scapula. My markers in the field. I have my shielding.
And why the abduction?
The abduction is going to pull the scapula away from the ribs. It's going to make it more longitudinal and upright. And it's going to pull it off of the anatomy that would obscure the scapula itself. All right, so I'm going to have you hold your breath, don't breathe, expose. You can go ahead and relax. Okay, so now we're doing a lateral scapula in the AP position. You may see it AP or PA position at the clinic, so we're going to show you both of them. So for the first one, I'm going to have you take your right arm and place it on your left shoulder. Very good. Now I'm going to rotate you just slightly. And just like the scapular Y, we're trying to get the scapular spine perpendicular to the bucky. So that's what I'm going to be feeling for. I'm going to be feeling for this, and I'm going to rotate her until that scapular spine is 45 degrees. I'm sorry, is perpendicular to the bucky. I'm going to make sure that I've got enough collimation to get the inferior border of the scapula as well as the acromion up top. My cassette is still lengthwise. All right. And hold your breath, don't breathe, don't move, and expose. You can go ahead and relax. Now I'm going to show you how to do a PA lateral scapula. So I'm going to have you turn around and face the board. I'm going to turn my marker around and put it on the other side so it still corresponds to the patient's right. For this one, I'm going to have you I'm going to kind of place your arm for you, kind of put your hand on your hip with the palm facing backwards. So the palm is facing behind the patient. I'm going to have you put your left shoulder kind of against the board, and then I'm going to rotate you just a little bit. I'm going to have you take a small step forward. Good. So for this one, we're accomplishing the same thing, but we're bringing the scapula closer to the cassette, so there's going to be a little bit less magnification. I make sure that I've got the acromion on there. I'm centered at mid-scapula, so scapula starts here and ends here, so right at the center. And then I'm entering right at the inferior margin of the scapula. And by doing this with the arm abducted a little bit, it's going to take the humerus off the scapula, so we can get a really good view of the scapular body in a lateral position. And I can collimate in on the sides a little bit because we are PA, so we're a little bit closer to the film. My marker's in there. I definitely have the bottom. All right. Hold your breath. Don't breathe, don't move. And expose. And go ahead and relax. Another option for your PA version of the lateral scapula is just a different arm placement. So your body is still going to be pretty much turned at that 45-degree angle, but instead of putting the hand on the hip, you put it over on the opposite shoulder, just like we did for the AP position. So you can also do that. And again, you just make sure that that scapular spine is perpendicular to the IR, entering at the inferior border of the scapula, mid-scapula, and it just basically pulls the humerus forward instead of back. So it still gives you a good lateral view of the scapular body.
Continuing in through the shoulder girdle, AC joints is, AC joint injury is actually rather common in sports, contact sports. You'll hear the term shoulder separation, and that's usually what they mean. It's a separation between the acromion protuberance of the scapula and the clavicle. So A for acromion, C for clavicle. This is always a bilateral study. Typically one side is injured, but they always compare it with the uninjured side because they're looking at measurements of separation. And what may look normal without weights is markedly separated on the with weight exposure. So we do bilateral study. Because it's going to see both sides at the same time, we're going to be doing this at 72-inch SID to reduce the magnification and have a better likelihood of getting both of the AC joints on the same projection. If your patient's shoulders are too broad, then you would do a with weight and without on one side, and then a with weight and without on the other side. But I think that he's going to fit all on one crosswise 14 by 17. Can you have your arms by your side, please? Okay, so his AC joints are going to be about right here. And I think he's going to fit on a transverse 14 by 17. I'm going to adjust my bucky up to the level of the AC joint. And the collimation on this is going to be 8 by 17. So I'm centered now right at the level of the manubrial or jugular notch, which is his mid-sagittal plane. And then his right AC joint is going to be about right here and his left here. So centered right in the middle. I'll place my both markers to indicate which side is the right side and which side is the left. Okay. Shield, and then I'm going to take one exposure without weights. Hold your breath, expose. You can breathe, don't move. And what I'm going to do now is I would swap out and put in another 14 by 17 if I'm using CR. And then without him moving, I would first add weight to the uninjured side. So I need you to hold this in your hand. The book tells you that you should attach the weight to the wrist. We don't have those types of weight here in the lab. These are the kind that you can hold. And then I'm gonna double check and make sure everything's set up ready to go, because he's not gonna hold this weight on his injured side for very long. All right, go ahead and just grab this. And then instruct the patient that they're just to let their shoulders relax. And then make a quick double check. Ready to go, hold your breath. You can breathe. And I would step right back in and remove the weight from the injured side first to relieve any distress that they might be under. And then the radiologist will look at both right and left sides on the same image and be able to take that measurement and tell if one looks more separated than the other. All right, the clavicle now, we do 2 projections. Since it's an oddly shaped bone and a very anterior structure, and it's also not an extremity that can be turned into a lateral projection, we have to do an AP with perpendicular central ray, and then what's called an axial view, where we angle 15 to 30 cephalad to project the clavicle off of the ribs and up above the rib cage. So if there's a fracture in the clavicle where it crosses the ribs, in the axial view, we'll be able to see it projected above the ribs. So I'm placing my right marker above the clavicle. For the first one, I'm going to do a perpendicular central ray. My SID readout now, I'm in the bucky, so I'll be at 40 inches, lined up with the center. And I'm going to collimate probably about 8 by 12. The clavicle is a very narrow bone, and I don't need to use a full 10 inches of collimation. So I would now align and detent and push my bucky in. Okay. His arm is at his side in a relaxed position. And my centering is going to be midway between where the clavicle meets the sternum and where the clavicle meets the acromion. So medial and lateral ends of the clavicle, and I'm going to be centering on the midpoint. So you can palpate the clavicle. You can actually sometimes see it, but you would palpate the clavicle midpoint, and that is where your central ray is going to enter. So I'd be sure that I had both medial and lateral ends, and then I'm collimated down, and then I would most likely in this instance put my marker above so that I can see it and make sure that it's not in the anatomy of interest. For this, he's just going to suspend respiration, hold your breath, and expose. You can breathe. Now for the axial view, I would swap out for a new 10 by 12. The degree of cephalic angulation that you put in it depends on the thickness of the patient. Extremely thin or asthenic patients are going to require closer to 15 degrees of cephalic angulation, and then the average to thicker patients require closer to 30. So I'm going to say that he is average. I'm going to angle 30 degrees cephalic, and for every 5 degrees of angulation, I'm coming down 1 inch. 5, 10, 15, 20, 25, 30, come down 6 inches. So I'll be at 34. Okay. Close your eyes because this might shine in your eyes. So you can see at 30 degrees angulation, I haven't moved my tube at all, but because of the degree of angulation, my light's all the way up here. So I'm gonna have to bring this down now until I am matched up with my IR. Okay, so I'm still detented. All I've moved is longitudinally, so I don't have to recheck a line and detent. This should all be still lined up, ready to go. I'm still going to palpate for my mid clavicle on the inferior aspect, and that is where my central ray is going to enter. Now, I've already got my Becky up as far as it'll go, and I have my table down as far as it will go. So I'm going to need to now pull my patient toward the foot end of the bed. I've adjusted my patient down. I'm giving myself a little bit of leeway, so now I can come back up where I need to be, palpating medial aspect of the clavicle, inferior margin. And so now with the central ray entering here, by the time it exits, it will have carried the image of the clavicle and projected it above the rib cage. I'll move my marker into the light field, and I'm ready to go. All right, take a breath in and hold it. Expose. You can breathe.